Support comes from Hampton Roads Community Foundation, partnering with donors from all walks of life to improve southeastern Virginia through grants, scholarships, and leadership initiatives. Learn more at hamptonroadscf.org.
Hello, everyone. I'm Barbara Hamley. For many women, it's a miraculous experience, the safe, uneventful pregnancy resulting in the birth of a healthy baby. But the frightening reality for far too many pregnant African American women is death. Their death or the death of their child. Why are so many Black mothers losing their lives or the lives of their children through what is supposed to be a natural part of the cycle of life? Up next on Another View on Health, Surviving Pregnancy. My co-host, cardiologist Dr. Keith Newby, joins me along with our guests right after this national, regional, and local news from NPR and WHRO News.
Discussing today's topics from an African American perspective, this is Another View.
Hello, everyone, and welcome to Another View. I'm Barbara Hamley. Before we get started today, let me give you my sincere thanks. The entire Another View crew sends its sincere thanks for your support of our pledge drive last week. We more than exceeded our goal, and we raised a whole lot of money in 1 hour. And so we are really, really grateful for your support of Another View. It is because of your support that we are able to continue to bring this program to you every Thursday at noon. So thank you, thank you, thank you. If you didn't get a chance to become a member last week, it is never too late to become a member. So go to WHRO.org and click on donate, and we will take care of you. Come join our family. We'd love to have you. So it's a trend that is absolutely going in the wrong direction. In 2019, 44 Black women died from a pregnancy complication per every 100,000 live births. That number grew to 55.3 in 2020 and grew again in 2021 to 68.9. Black women have the highest maternal and infant mortality rates than any other race or ethnicity. But the question is why? And what do we need to do to reverse the trend? Joining us with some thoughts is Dr. Edward Karotkin, Professor of Pediatrics at EVMS. Hello, Doctor.
Hi,
How
Barbara.
are you? Thanks so much for joining us. LaVern Morris, who is Administrative Support Manager at Children's Hospital of the King's Daughters Communication Center and Pediatric Literacy Program, and she also managed a program called Resource Mothers. How you doing, LaVern?
I'm great, Barbara. Thank you for having me.
Thank you. And my co-host for Another View on Health, cardiologist and all-around good guy, Dr. Keith Newby. How you doing?
I'm doing well. How are you? And congratulations on your fundraising ability.
Thank you. Listen, I would say I was impressed, but I know it's just your good work that's doing it.
So, listen, congrats again.
Thank you. I really appreciate that. So let's talk about this issue. I was stunned that the numbers from 19 through 20 through 21, they keep going up in terms of women dying, their babies dying, unfortunately, through childbirth. Why are they getting worse instead of better, Dr. Gay? And you said, Ed, I could call you
Please
Ed
do,
on the
Barbara.
air, right?
That'd be great,
Okay.
sure.
All right.
I think it's a complicated issue, and there's no simple answer. I think some of it is related to the COVID epidemic, and there was certainly evidence to suggest that mothers, pregnant women who had COVID had a higher incidence of death and had a higher incidence of prematurity and delivering a premature baby. I think there are other factors at play as well. There are economic factors, inability to get adequate prenatal care or limited prenatal care. There's socioeconomic factors, lower incomes, less availability of vitamins, and the ability to get access to prenatal care
that they need and so forth. But this is not a new issue, is it, LaVern?
No, it's not. We actually began addressing this back in December of 1996 when we received this huge grant, $500,000 grant from the Virginia Healthcare Foundation to start a Resource Mothers program in the city of Norfolk. And initially, they wanted us to just focus on teens in low-income areas. But over time, we discovered that it wasn't just teens, it wasn't just moms up to 18 years old, but other women were coming to our Resource Mothers and saying, "Well, how can I get some help? I'm going to be a single mom. I don't know how to do this." And so, we went back to Virginia Healthcare Foundation and approached them about expanding our age range, and they agreed. And so we ended up with about 30 Resource Mothers all over the city of Norfolk, helping these women through their pregnancies. And the beauty of it is that I would go into the churches and to the PTA meetings and into the health department clinics and recruit these women who actually lived in the neighborhood. So they felt safe going into their own neighborhood and working with people from their neighborhood to go into the homes and work with these moms one-on-one and help them to receive access to care and work with them through, getting them into social services, filling out paperwork, knowing what questions to ask when they went to the doctor's appointment. They'd help them make a list. What do we need to ask the doctor today? Let's talk about this before you get into your appointment. And so, they really became that mom's go-to person. Even in the middle of the night, we had some cases that occurred in the middle of the night, and the Resource Mothers would
they would have to be there 24.
They were there
24 hours a day.
Yeah.
Mm-hmm. So, Ed, what was the? Well, let me back up for just a second. I would love to hear from those of you out there who either are pregnant now or just had a baby. If you had a concern about your pregnancy, and also if you are serving as a doula. We would love to hear from you. 757-440-2665 or 1-800-940-2240. Those are the numbers to call to join our conversation. 757-440-2665 or 1-800-940-2240. So, Ed, what was the reason for starting the study in the first place? What was going on?
The real impetus for the study was the observation that I had and my colleagues had working in the neonatal intensive care nursery at the Children's Hospital at King's Daughters, was seeing the disparity in the number of babies that were admitted born to African American mothers versus their white counterparts. It became apparent that for a variety of reasons, African American women were having a higher rate of premature babies, small for gestational age babies, babies with complications compared to their white cohort mothers.
And so you got started there. And Keith, in your work with public health and health disparities, we know that this is an issue that is not limited to the lower socioeconomic range, but for Black women in particular, it's across socioeconomic levels.
Yes, definitely. And some aspects of racism will kick in and puts putting the cards on the table. A lot of women may not necessarily feel that they have a trusted source to go to and to have discussions with about it, and how they're spoken to. One of the biggest concerns I've had just in my day-to-day practice as I've worked through the hospital is having patients that tell me that the way they're spoken to can evoke either trust or mistrust. And that is something I think that's a real problem, and that could be cultural differences, and you hear the term cultural humility. A lot of people may not necessarily possess that quality, and it's not that it's necessarily an intentional finding, but it's a real problem that we see every day. So that also impacts, I think, on the ability of women to come and seek treatment.
Along those lines that Dr. Newby's mentioning is there's some studies that have shown that Black women's concerns are not taken as seriously as a white woman's concerns, or the response to her pain does not get the same response that a white woman might get.
Which is so interesting. So you're teaching at EVMS
Yes.
As a professor. Is there a difference in terms of raising the level of understanding, cultural understanding, in terms of classes now for upcoming doctors as compared to, say, when you started the Resource Mothers?
I would say to some degree there is. I think, in all honesty, probably we could do a much better job of teaching cultural diversity than we do now, but certainly we try to stress that in our conversations with our students.
And Keith, do you find that's the same in your area of expertise also?
Yeah, it's just the hardest part, and I'll just be, again, putting cards on the table.
Mm-hmm.
When I came through, and I'm feeling like an old dude now, but when I came, when I came through, I trained at Emory in Atlanta, so Grady Hospital was a big county hospital there, and they really emphasized communication skills. In my medical school class and residency and fellowship, that was a big thing. With this advent of social media and texting, and I'm finding the younger physicians and providers don't have that same level of communication skill, and I think that does impact. And of course, that's up for debate. But in what I see is there is a lack. Prime example, taking the simple social history. You will find a lot of people skip that, but that is a vital part of a history and physical exam, because that, when you start getting to those social determinants, that helps you to understand where this person is in terms of their life, their the challenges they may run into. So when you're creating your care plan for a patient, you're able to take those things into context. If you're going to give somebody, like an example, like a brand name drug for hypertension, if they say, well, I'm in a position where I'm unemployed, or I'm working at a place where my income is low, I have 5 kids to feed, and you're going to give them a brand name drug that's going to cost them a gazillion dollars, that's not going to work. And a lot of patients may be embarrassed to say they can't afford something, they just don't get it, or they buy it, but they kind of like take it every few days, which is not helping them in that context. So that's the things that I think that social history we don't do like we used to do, and that's an unfortunate reality. And again, I would like the rest of your panelists to chime in, because they may feel differently, but that's what I see that can create a lack of connection, because you want to connect with the patient so that you earn that trust. And if you really show and demonstrate that interest in them individually, you will find the return investment, meaning their trust coming back to you, can open up so many doors in terms of your ability to take care of patients.
Yeah, absolutely. So do me a favor. Let's go back and give people the nuts and bolts of the study. How many women?
Okay.
What did you find out? That kind of thing.
Over about a 2.5-year period, there were 589 women that we were able to take care of during that period of time. And there were 284 infants born during that 2.5-year period. And what we were able to do is compare the results of the babies born to resource mothers to a control population of mothers born to a Medicaid group of women who presumably did not have the help that a resource mother was able to provide. And we looked at a variety of indicators of infant health. One of the primary ones is called infant mortality, and that's the measure of how many infants die per 1,000 babies during the first year of life. So, for example, in the white population, it may be 5 or 6 per 1,000. In the African American population, it's probably closer to 10 or 11 per 1,000. So it's twice as high. Another determinant of newborn health would be low birth weight or prematurity. And in the African American population, typically they have more low birth weight babies, more premature babies. In our resource mothers group, we compared the birth weights and the prematurity rates to those of a Medicaid population. And again, the resource mothers' babies were bigger and more mature than were babies in the control group. Lengths of stay were shorter in the resource mother group. So virtually every indicator of a newborn's health was improved in a baby born to a mother who participated in the resource mothers program. The only area which we did not see improvement was in breastfeeding, despite having the resource mothers teach the mothers the importance of breastfeeding. We think the reason for that was because so many of these mothers who were in the resource mothers program went back to work or went back to school, and the care of their baby was turned over to their mother or their aunt.
And so it was difficult for them to continue
It
to
was,
do.
but virtually
to do
for
breastfeeding.
every indicator for the health of a baby, if you participated in a program such as Resource Mothers, the outcome was much better.
LaVern, so take me to a typical visit. What would the women who were the resource mothers tell you? What would the moms to be tell you about their experience?
So the resource mothers would, of course, go into the home and not really do, I wouldn't say a full written assessment, but I thought it was always important for them to go into the home and kind of see the environment that the mom would be bringing this baby into. Sometimes there was domestic violence, sometimes there were drugs being sold, sometimes there were drugs being taken. We just never knew. Sometimes they never got support from their family members. They just felt all alone. So making that initial connection and establishing that relationship, as you mentioned, of trust was vitally important. And I think with the resource mothers coming from their community, somebody that they would see coming around the corner, going to the grocery store or going for a walk in their neighborhood, was vitally important to them, because it was like, okay, well, she's right here. She knows what I'm going through. Sometimes the moms of these young teens were resentful of the resource mother being there. We ran upon that several times because they thought the resource mother was trying to take their place. And so we'd always have to say, I'm not here to take your place. I'm just here to help your daughter get some support during her pregnancy. And, as Dr. Newby said, back in the day, there was a school in Norfolk where if a young lady was pregnant,
The Coronado School
on Weegen Road, they could go to that school and they could take their baby. So we had a lot of connections with the school as well, where, we could pick the mom up and pick her baby up and make sure they got to their prenatal appointment, or make sure she got to her prenatal appointment, or the baby's appointment is what I'm trying to say. So, the day in the life of the resource mother could extend to, at one point we had a mom that was at a 7-Eleven in a low-income neighborhood in the middle of a nor'easter, and the resource mother called me and said, what do I do?
Wow.
She wanted to leave her baby at the store, and she did leave her baby at the store. So, the resource mother had to go get the baby. It's 1:00 in the morning. We can't call social services at that point. So we had to wait till the next morning, get in touch with social services, make that connection, find the mom, so it involved a lot, but it was important for the resource mothers to also have those connections with people in the social services department, or the health department, or community services board. So we always made sure that those folks came in to do trainings with the staff, so that if the resource mothers had to call on them, they would know where they needed to call.
How did you recruit your resource mothers?
By going into the schools, the PTA meetings, church meetings, whatever community meetings, community civic league meetings, whatever meetings that were held within that community that I could get into and talk about resource mothers and find out who was interested in becoming a part of this program is where we went.
Let me just add something to what LaVern just said. One of the most important functions of the resource mother was to make sure that their women that they were in charge of got to the prenatal appointments. Many times, by identifying a problem that a mother had well before she was due, could avert having a premature baby or improve her health. As you know, African American women have a higher incidence of diabetes and hypertension. And if those health problems can be identified early, prior to the delivery, they can be addressed and treated. And in doing so, you would not only improve the outcome of the pregnancy, but also improve the outcome of the pregnant mother.
Keith, do you deal with a lot of pregnant people in your practice?
In the cardiology world, yeah. I mean, we'll get a lot of patients who come in with shortness of breath or chest discomfort, and especially palpitations and tachycardia. That's probably like the biggest, or fast heart rates. That's probably the biggest complaint that I see. And we will do, and there are patients who develop cardiomyopathies or weak heart muscles. It's like an immune system where your immune system fights. The baby is fighting your immune system, and it damages the heart. So you do see that periodically, and that's probably the biggest thing that breaks your heart. And I remember a patient I had who became pregnant and had this was years ago, but she had a cardiomyopathy. The heart function dropped down to 15%, where normal is 55% or greater. And and I really try to counsel her continuously about not getting pregnant again, because that is something that we kind of emphasize. If that happens, because the likelihood of that happening again, if the heart does recover, there's a high likelihood that it could get worse on a second pregnancy. So you have those counseling sessions, but this particular patient, when I got pregnant again, and unfortunately so died in the emergency room from a heart rhythm disturbance while she was pregnant. So both she and the baby died. And that was an unfortunate situation that, again, in our world, sometimes it's hard. You counsel patients, but without kind of being in the home and really be able to reemphasize the importance of trying to keep them from at least look at abstinence or some way of not getting pregnant, protecting themselves, whatever it takes, it could become challenging. And then it just breaks your heart to see. This young lady was only, I think, 22, 23 years old, and lost her life as a result of this problem. And what do you do? I mean, it's a tough road. So it really does kind of take you down a different path, at least for me. So yes, I do see cardiac manifestations, not as much as some of these other issues that you hear about, like the hypertension and the diabetes. And I'm going to tell you, a lot of people blow that off, not provider world, but patients, they don't think it's a big deal when they have this, because typically they don't feel these diagnoses. You don't feel diabetes characteristically. You don't feel hypertension, but that can be devastating to both the patient and the baby if the blood pressure remains so high, cause kidney failure and a whole bunch of stuff.
That's preeclampsia.
Preeclampsia.
Yeah, preeclampsia.
Again, it's more common in the African American population than the white population. And more common in teenage pregnancies as well.
Just like one question I wanted to ask, just out of curiosity, that school, because I remember when I was in high school, of course, that was many moons ago. I remember that.
Come on now, Keith, telling your age.
Listen, I'm just keeping it real. I was at Moore High School right down the street from where I am and wherever you are. And I remember there was a school that, sometimes, it's hush-hush back then. You didn't talk about when girls got pregnant. They would just disappear for, a year. And they would come back the next year having had the baby. So I knew there was a school that a lot of women went to. But so I'm assuming that school is no more?
No, it's not.
Yeah, it's gone now.
So what happened? Yeah, what happened with that? Was it funding issues or what?
I think they just reincorporated the students into the general population, I think, but I'm not positive. So anybody listening from Norfolk Public Schools, give us a call and let us know. What's going on.
I thought that was because you think about the extra potential attention you could get, because you think about if you're in a big classroom, you don't have that kind of time to really dedicate to one student when you have a whole class full of kids you have to deal with. And it seemed like that was a better. I mean, I felt, and the girls kind of going, I'm not in this world, but I would think that would be better having that resource, than to just put them in the general population, so to speak. But tell me if I'm.
Well, I think you're right. They not only got support from programs and services, but they also received support from their teachers and from other young ladies that were going to the school with them. So, they became a community kind of within themselves, which was great.
757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. We're talking about prenatal care. We're talking about infant mortality and maternal mortality and what we need to do in order to turn the numbers around and make them go down as opposed to going up as they are right now. And if you're just joining us, we are talking with Dr. Edward Karotkin, professor of pediatrics at EVMS, and LaVern Morris, a children's health advocate who led the Resource Mothers Program, and my co-host for Another View on Health, cardiologist Dr. Keith Newby. 757-440-2665 or 1-800-940-2240. Are you guys, it sounds like you were ahead of the curve, number one. Did you consider the Resource Mothers doulas, as we know the term doula today?
I think so. We of course didn't call them doulas back then. They were just lay healthcare workers. But like I said, we took the time we probably did more training than most, because training every month was important. They had to attend the training. It was mandatory, whether it was CPR or substance abuse. They came to the hospital and they sat in the conference room. We'd have NICU specialists, Dr. Karotkin or some of his colleagues or NICU nurses come in and talk to them about different things that they could do to help encourage the moms to come and visit their babies should they be in the NICU. And I think a lot of it was, and I think it was Dr. Newby or Dr. Karotkin one that mentioned earlier about, why they don't go for prenatal care. There were always a lot of other stressors that needed to be addressed and eliminated to kind of get them to that point of wanting to go and get prenatal care and seeing that as a priority. And that was one of the things that the Resource Mothers did. And whether it was nutrition or, they couldn't pay an electricity bill or they didn't trust the doctor they were going to, whatever it was, they helped to kind of eliminate, address those stressors and kind of get them to the lower end of the spectrum so that they could focus on their health and their baby's health and having a successful pregnancy.
There are a lot of complex reasons why women don't get prenatal care, but it could be as simple as not having taxi fare or bus fare or a working car to get yourself from your apartment or your home to the doctor's office. And that obviously is a very significant reason why a mother might not get prenatal care.
But there's such a difference between, even with other minorities, Black women are experiencing this death rate at a higher rate. I know we always compare it to white women, but even to Hispanic women and Asian no, I'm going to get it wrong. Asian women, Pacific Islanders. That's what I was trying to say. But even in those groups, their numbers are not as high as for Black women. So, Keith, what do you think is that determining factor? Why is it so bad for Black women?
Well, it's probably multifactorial, but I think one is just the general health of the person itself. If your health is already challenged, going into a pregnancy is just going to get worse. If you think about, is it really so much a genetic factor as it is a lifestyle factor, or like you say, access to health, or even think about if somebody's trying to work and their doctor's office closes at 5 and they don't get off till 5. There's so many variables that lead to this problem. But I personally, and again, I have no data to support this assumption, but I think a lot of it is just based on the health of the person going into the pregnancy that may be part of that factor. You think about just lifestyle, are they house insecure? Are they food insecure? What types of, what's their living arrangement like if they're in the house with multiple people and, they just have no room. And this just a quick story. One of my cohorts with Centera in health equity, Centera had they had this storehouse. They were moving out of the storehouse and found they had all these beds that some company had given them years ago, and they were trying to, just giving these beds away to people who needed them. They were regular, just, I guess, twin beds or whatever. And if you wouldn't imagine how many people, once they made an announcement, they had like several thousand beds, and they were getting where they just went like a couple of days because there were people who had never owned a bed before. If you think about something like that, where you have somebody who sleeps on the floor,
Mm-hmm.
They've never owned a bed in their life, and they had access to this. So you think about just the living conditions that some people have and live in, and their ability to, if you're living in poor conditions, your ability to be healthy is going to be challenged just
That's
right
correct.
there alone.
Mm-hmm.
So those are the things that I think impact, and I think it really goes back to that social determinant of health factor, because if you look at just brass tacks, 80% of illnesses are typically related to some aspect of social determinant versus 20% that just their health is poor. But that factor of their ability to get access and understand, what their condition is and how they have to, how they have to live with it, or how they can manipulate it in a positive way, they just don't have that information.
Ed, when you see your patient is the infant, obviously, but when you see the mother also, do you spend a lot of time talking with her about what's going on at the home, or what other factors she may be facing as she's trying to deal with a baby that's in NICU that's really sick, or that she has to help build up,
we certainly do, and we encourage not only my colleagues but the house staff, the pediatric residents, the nurses, to engage with the mother at the bedside, to make them feel comfortable and to provide them with all the relative information regarding their sick newborn.
Yeah, because I'm sure that's just
it's very important to develop a relationship with that mother and father going forward, because oftentimes these patients are in the hospital for many days and many weeks or months.
And one of the things that we're doing now, Barbara, it's great to see that there's still some programs out there like Birth in Color that are focusing on women's health and pregnancy. But in reference to the NICU, one of the things that we're doing is we have the very first Reach Out and Read program in the state of Virginia in our NICU. So the national office has sanctioned our program. And what we do is, because the parents come in and there's so much anxiety around, what can I do for my baby? And they want to contribute, but that baby's in an incubator. They can't pick them up and hold them and rock them like you would your normal baby if you're taking them home. So we provide a booklet entry once the mom and the baby, or the parents and the baby, are in and settled. We have a family support worker or one of the nurses or case managers come in with a book that they can read to their baby at bedside. And we encourage them to do that to help develop those cognitive skills. And for them to bond with their baby and hear their voices. Wow. And then every 4 weeks that they're in the NICU, they get a brand new book. And at exit, they get another book that they can take home, with them and continue to read. So we start that literacy piece at birth, and we follow them until they're out of the NICU. And they even earn NICU bucks that they can go into the little NICU store and they can buy additional books that they can sit at the bedside and read. So just that little bit gives them that level of comfort and knowledge that they're contributing to their baby's health. At the same time, there's really not much else they can do.
And there's something that they can control.
It's something that they can control. And, we don't ask the neonatologist to introduce that book when they go in, because their focus at the time is, what that baby needs and what kind of care we can provide and to get this baby out of the NICU and get them home. So, it's introduced maybe a day or two later. And it's really comforting to the parents. So, there are a lot of things that you can do to kind of help that mom or that family be accepting of that child and contribute to that child's care and development.
I want to go back to talk some more about kind of the cultural competence and the way that African-American women in particular and healthcare professionals interact with each other. Because I'm thinking about when my granddaughter was born. And there was a woman there who helped with helped you to set up your baby seat, car seat. Okay. But so she gave us a sheet and said, use this kind of car seat, by this manufacturer, and this is where we'll go, blah, blah, blah. So I did my own research and found a different manufacturer, a different car seat, but had all the safety features, yada, yada, yada. And the attitude towards us, because we chose a different car seat than she had recommended, was unbelievable. I mean, it was to a point where I had to say to her, this is who I am, this is what I do, and I have done the research, and you will use this seat. Now you're either going to install it and make sure that we're installing it correctly, or we'll go somewhere else to do that. And there was this, because she kept calling them my girls. And there was just this kind of attitude that if you don't listen to what I say, then you're wrong, And I think that that's so important, that whoever you are, that you are listening to the patient and listening to what they're trying to tell you, right?
You have to listen, regardless of their cultural background, their nationality. You have to listen to them, and you have to recognize that where they're coming from ethnically or culturally is very different from where you're coming from. And, to present something to them in a way that's acceptable to them, not acceptable to you. And that's very important.
One of the things that I stress when I'm teaching third-year medical students who are on their way to becoming physicians, the importance of, even before you examine your patient, talk to your patient. In my instances, it's the mother who may be getting ready to have a baby or getting ready to have a cesarean section. Go in, introduce yourself, tell her that you're going to be in the delivery room, you'll be taking care of her baby. And oftentimes, you can learn an awful lot about what some of the medical issues that baby and the mother is going to face just by listening, without doing a physical exam, without looking at any of the laboratory work, just by listening and talking. Yeah.
And also, so the resource mothers, did they also serve as an advocate for the mom once they got into the healthcare system?
Absolutely. And oftentimes, especially if you were dealing with a teen mom, a young mom, they really didn't know what to ask when they went in. And, of course, HIPAA is extremely huge now. It wasn't as huge back then. So it was nothing for the resource mother to go in with the mom on her exam, or be there in the delivery room when the baby was delivered. If she didn't have any other support, they were that mom's advocate.
I think they also had a role in making sure that the baby during that first year or two of life got immunizations, and I think that the rate of immunization was higher in the resource mother's book.
So they really started from when the mother was pregnant, all the way through the first year
of life. Yeah. Yes.
Wow. So what are some of the complications, and Keith, maybe you can chime in on this also, that cause women after they've had the baby, because there's still maternal deaths even after the child is born?
Actually, if you look at that statistics, about a third of the deaths occur prior to the delivery, a third occur during the delivery, and then a third occur after the first week of delivery during the first year of life. And in those situations after delivery, it's things like high blood pressure, diabetes, infection, maternal hemorrhage.
Wow.
So there is a fair amount of maternal, we call it morbidity and mortality, that happens well after the delivery of the baby.
So, Keith, should there be a campaign, particularly to tell pregnant women about this high blood pressure thing?
Yes, I think, it kind of has to even go deeper than that. I mean, you almost have to, that needs to be almost part of just daily life of understanding of your medical condition. Some of the times we do the show and you'll ask me a question, I say the first thing is getting people to go to the doctor. Because a lot of folks they feel like they're young. They don't have to worry about anything. You know how many 15-year-olds I have seen? I don't really see children, but every now and then my arm would get twisted from some family member to see a young kid, and they come in with a pressure 180 over 100 who's 15 years old. And you just would be amazed at a lot of what they eat. I mean, they have a genetic predisposition for hypertension, but they're eating fast food every day, cans, things with sodium content through the roof, their pressure is going to be high. And again, it goes back to if you're asymptomatic, meaning you don't feel anything, and people blow that off a lot of times because they just don't know, they don't understand, and they're young. When you're young, you feel like you're invincible, you're going to live forever, all those things that you think and you believe, but the realities are that's not always the case. I mean, granted, yes, you do better than somebody who's, 70, 80 years old, health-wise, generally speaking, but there's still challenges you have to be aware of. So that's kind of what I see.
So I have a question. Is there a difference between a younger mother, teens through up to 30, and women who are deciding to have babies at later in life, 30,
no question
40s?
about that. The statistics would bear out that the incidence of complications and prematurity are higher in teenage pregnancies. Mm-hmm. They seem to be the lowest in women who are in their 20s and maybe mid to late 20s. And then as a mother gets into her 30s and 40s, the incidence of problems rises as maternal age rises as well.
Mm-hmm. And by that time, especially when they're in their 30s and 40s, if they've been diagnosed, Keith, with high blood pressure or with diabetes, what things should they consider if they're talking about getting pregnant?
Well,
what's the question to ask?
Well, I think the first thing is always understanding your health and where it is. If you have blood pressure that's never been well controlled, or you're diabetic and your hemoglobin A1C, which is one of our markers we follow, is greater than 7, your relative risk goes up. So really, is just understanding where your health is and where it has been, because you've been living with an A1C of 14 forever. That means you're going to see blood sugars of 400. That the potential when it was mentioned earlier about infection. Your infection rate goes up when you're diabetic, and that's not well controlled. It's diabetes, period. But in an uncontrolled diabetic, it's worse. Mm-hmm. So these are the things that you have to be addressed early on. So I think the first thing is always, if you, especially when you get into, when you're in that late teen, early 20 range, I mean, seeing the doctor once a year, I mean, it doesn't take that much of your time to go do that and see that, and really understanding not just your history, but your family history. And that's where you'll run into a lot of problems because, especially in our community, we don't want to talk about our health that much. So we kind of keep things to ourselves. You know how many family members that say they don't have a clue what their other family members have, and if they don't have one clue because they don't talk about it. So that is something that I think we have to open up about our histories, not if nothing else to help protect those younger than us, to really let people know if this is an issue, you have to be aware that it's an issue because I had it and I don't want you to have the same thing. Mm-hmm. So that communication has to be there.
I think Dr. Newby alludes to the importance of prenatal care too when you're early in your pregnancy, so you can identify these risk factors such as hypertension or diabetes or obesity, which can oftentimes be addressed successfully before the baby is born so that you prevent either a maternal problem or a problem affecting the baby.
And LaVern, you were talking before about in the program helping women to ask the right questions. What would you tell them? What questions should they be asking today?
Wow. Well, I mean, I think one of the things that, if there was a resource mother or a lay healthcare worker working with a young woman, I would advise them to talk, like you said, talk to their parents and kind of find out who in my family had high blood pressure or who in my family had diabetes. And then when they go in for their prenatal care, find out if they're at risk for any of those things. Ask those questions of the pediatrician. Ask about nutrition. What should I be eating? What's going to give me the best outcomes? What about the prenatal vitamins? What should I expect at the end of my pregnancy? When I get ready to deliver. Where am I going? Where am I going to deliver? Who can be in the room with me? Even those softer things, I think, are important for that mom to know and feel comfortable.
And women who are living in rural areas or areas where hospitals have taken away the delivery rooms and so forth? I mean, is that's even a concern in terms of how you're going to get to?
That's
Exactly.
That's been identified as a challenge too for pregnant women, particularly lower socioeconomic pregnant women who live in a rural area where there's no access to adequate prenatal care, and they may have to drive 50 or 75 miles to their prenatal visits. Also, they may not have the availability of a high-level hospital such as Centera or Children's Hospital, the King's Daughters, and they're forced to deliver a baby in a lower level of care hospital where there may not be the expertise in either physician care or the technology to take care of the mother or the baby in a high-risk situation.
And while we still...
hang on 1 second, Keith. Go ahead.
Go ahead.
And while, we don't, quote unquote, have programs called Resource Mothers here in Hampton Roads area anymore, there are still a handful of health districts that still go by Resource Mothers, and they're implementing Loving Steps and Healthy Start and Healthy Families. So there are programs out there that that families or young women can, access. And the question is, will they, and who's going to help them to get there or identify those resources? Yeah.
Actually, I did a very quick Google search before we came in and found three different doula services, which are lay people who will help walk you through the process in the Hampton Roads area. So be sure to do that if you did it. Dr. Newby.
Yeah, just quickly, you remember, Barbara, we did a show about this about a year or so ago about hospitals getting rid of their OB program, and we talked about that issue. So that's even super more important. I don't know of a better term to say that you have that prenatal care, because if you are, like, say, living, and I don't want to say anything about which hospitals gave it up, but I'll say.
But if you live in a city.
You live in a city where a hospital that used to have an OB program no longer has one, that means you have to be more prepared as to how that delivery is going to go forth, what that prenatal care that you need, so that you are best prepared when it's time to deliver, that there's a plan in place, because that is what we're seeing. Some people have them at home.
Right.
So if you have that reality to deal with, that means you have to be super prepared for what may come out of that. So, and I understand it's a money thing for a lot of these hospitals. They've gotten rid of it because it's just a money loser. But the bottom line is people need care.
And people are still having babies. And guess what? Yep. We're out of time. You all, thank you so much, Dr. Ed Karotkin and LaVern Morris, and always Dr. Keith Newby, for joining me today and for another View on Health. We really appreciate it.
Thank you, Barbara.
And we will be right back.
Hi, I'm Claude McKnight of Group Take 6, and you're listening to Another View.
There's a new sun rising. I can see a new horizon. You keep me realizing you're the biggest part of me.
And welcome back. He's Norfolk Public Schools Teacher of the Year. He's also an incredibly talented artist, author, and poet. His name is Clayton Singleton, and it's been 4 years since the last time Another View producer Lisa Godley sat down with the Lake Taylor High School art teacher who never shies away from telling powerful stories that capture the heart of our community with vibrant colors and bold strokes.
My process of creating works like this, I have an experience. And that experience takes me through all my other experiences I've had, and I find these connecting points. Once I do that, I kind of think about, how does that connect me to people? As an artist, I work a lot, and it's not just physical work, it's a lot of mental work that goes into the pieces. And it's like I'm on this emotional archaeological dig a lot of the time. I'm searching for how can I say what I feel. And that's hard to do, to translate it. So this piece, Keys to Success, This typewriter is a typewriter that my grandmother had forever. You have to do the work to write your own story. And the typewriter represents that for me. Like those hammer keys, you can just see them going. There's a certain amount of strength you have to get it done. And when you do make a mistake, you have to actively correct it. It's not a backspace. There are no little blue lines beneath it to let me know I made a mistake. I have to have the conscious act of, I made a mistake. And being able to recognize that represents what we have to do in our lives. Because otherwise, people write our stories for us. And right here in this little tiny lettering, right above the ribbon, it reads, "In the beginning." I love that. You know, it's the story. It's that one that you choose to write. My grandmother's a big influence in my life. We went to her house every single day. She was on the Civic League, and sometimes they would have pre-meetings at her house. So I understood the power of social activism and the responsibility of civic activism. When it's time to vote, you go vote. You have to literally jump into your civic life. You have to jump into citizenship. And it's like double dutch. It's like you have to catch it. And then when you do, you jump in, and sometimes you get hit by that rope. Did a piece called Far From Manna. It interviews with people as to what it's like living in a food desert, what things happen, what things don't happen, what are your greatest needs, what are your greatest fears. So I did things like I caught the bus because they told me about the number 4 bus would take them to the Food Lion. I saw the bus go by. I was like, Lord, you know, my first word was spoil yourself. I was about to call an Uber. I had pulled up the app. I was like, oh, somebody's 7 minutes away, you know? And then I was like, they don't call an Uber. They have to wait for that next bus. So I stood out there with my few bags, you know, waiting for the bus. Imagine if I had for real amounts of groceries. How would I do this? What if I had small kids with me? How would I do this on a daily or weekly or monthly basis? And all of those things resulted in the painting that was like 54 by 84 inches because it needed to be large. This is for each artist and person whose mission is exposing personal, community, and global issues, working toward the progression of humanity. This is for each of you who's ever thought or dreamed of making a mark from birth, letting the world know you danced on this earth, even if only for a short while. This is for us. Too often we treat our history as rubble, something to forget, something to erase, something of which to be ashamed. But your history is your cornerstone. It's your birthright of existence, and you have to build on that. My job is to tell the story while I'm here.
Wow. Last summer, Clayton was an artist in residence in St. Croix. The result was 5 new pieces of art, one of which will be on display at the Caribbean Museum Center for the Arts starting in April. Meanwhile, back here at home, he started an artist cafe for his students, which showcases guest artists who share their knowledge by hosting workshops. I hope you've seen some of his artwork. He is just absolutely fabulous. Thank you so much for joining us here at Another View and sharing an hour of your life with us. Our guest shared some vital information about being Black and pregnant that you may want to share with others. Go to anotherviewradio.org and download the podcast. And you can find all of our past broadcasts by strolling down to the bottom and clicking on View Show Archive. Next week on Another View, the psychological component of how we view money with Dr. Angela Reddix, author of She's Got the Power. Our theme music is an original composition created especially for Another View by Jay Sennett. Special thanks to Dr. Barry Graham for filling in as show producer for Lisa Godley, who is on assignment. Jordan Christie is our audio engineer, and Danielle Saunders answered our phones. I'm Barbara Ham Lee. Thank you again for showing your love for our show by becoming a member of WHRO Public Media. And let's get together again next Thursday at noon for Another View.
Support comes from Hampton Roads Community Foundation, carrying out your charitable wishes forever, whether it's helping shelter animals, feeding the homeless, enhancing the arts, or supporting students. Learn more at leaveabequest.org.